Hello one and all. We recently had World TB Day on March 24th. Today we have with us Dr. Bharath, and we would like to use this opportunity to raise our understanding and awareness of childhood tuberculosis. Dr. Bharath, what is childhood tuberculosis like, and is it common in children?
Yeah, of course. Childhood tuberculosis is quite common in children, and with the rising resistance which we are seeing in TB right now, we have shifting our focus a lot onto childhood tuberculosis right now. They say that almost, let's say, 10% of all TB cases which are diagnosed is actually childhood tuberculosis. But what we need to understand is childhood tuberculosis is really difficult to diagnose. So a lot of cases actually end up going underreported. So yes, childhood tuberculosis is important, but we're probably underdiagnosing childhood tuberculosis. And hence we need to start shifting our focus into understanding this disease much better and learning how we can diagnose it faster.
And who do we suspect to be having TB?
So tuberculosis in children, when we suspect is, let's say a child comes with pneumonia and the pneumonia is persisting for a very long time, or the pneumonia is not responding to your routine antibiotics, then your doctor would probably suspect whether the child is having tuberculosis. If a child comes with cough symptoms which are persistent for more than 3 weeks, or if the child is having a weight loss, yes, we do suspect tuberculosis then. What we also need to realize that is tuberculosis in children is not always lung related. It is not always pulmonary. We also see 50% of cases are actually extrapulmonary tuberculosis, which involves organs other than the lung. So a child could present with features suggestive of meningitis or brain fever, which could be because of tuberculosis. Or we can also see abdominal swelling or abdominal distension for a long period of time, which can be TB. Or we can also see swellings in the neck in the form of lymph nodes, which can be tuberculosis. It's also important that if any person has been exposed, or we have even a doubt that a child has been exposed to somebody with tuberculosis, these are the patients we tend to work up on. So this entire spectrum of both lung as well as extrapulmonary tuberculosis is when we suspect this child to have TB, and we start our workup on these patients.
And how do we go about diagnosing TB in a child?
As I said, see, diagnosing TB in a child is not an easy thing. It's quite a difficult problem. Mainly, the main reason is if we need to say tuberculosis, we need to have the bacteria present. So the moment we see the bacteria, we're sure that tuberculosis is there. But isolating this bacteria in children is very, very difficult. So the test that we usually do is, firstly, we do something called as a Mantoux test. A Mantoux test is also called a tuberculin skin test. So we apply this Mantoux antigen onto the forearm, and then we see the reaction. Now what we are looking for there is we're going to see whether this child is actually exposed to the tubercle bacilli or not. Now if a child's immunity is good and still Mantoux has come negative, it's unlikely this child has been exposed to tuberculosis. Now if the Mantoux comes positive, or we're suspecting tuberculosis, we next need to show that this bacteria is there or not there in the child. So we do something called as a gastric lavage. Now remember, in adults what they do is they do a sputum. They're able to bring out sputum test. Children do not bring out sputum. What they do is, children, though they produce the phlegm, they tend to swallow it and it goes into the stomach, right? So we need to insert a tube early in the morning into the tube, bring out all the stomach contents, which is what we call as a gastric lavage, and we send that for identifying the bacteria. Now we can identify the bacteria by either just regularly staining it, which we call as an AFB stain, or today we are so advanced right now across the world where we do something called as PCR or a TB PCR, which is much more sensitive. Even if there is one bacteria or two bacteria, we can identify it in that sample. So today the general recommendation for children is, yes, we will do a routine blood test, we will do a chest x-ray to see whether there are signs of tuberculosis. But in addition to that, we do what we call as a Mantoux test, and we do what we call as a gastric lavage to identify this bacteria.
And is it treatable, or in Indian context, are there many roadblocks to it?
TB, what we all need to realize, is a treatable condition as of now. Yes, the biggest roadblock we're having is resistance. We're beginning to see that yes, these bacteria are becoming resistant, but by and large, let us understand that tuberculosis is a treatable condition. We all need to accept that and treat the child early. The drugs that we have for tuberculosis, a lot of the bacteria are still responding to it. But the biggest problem we face is that parents don't give the treatment completely, or even doctors or even medical professionals, we are not able to diagnose TB rightly in children, which is either a reason why it is underdiagnosed or it is overdiagnosed. So children who may not be having tuberculosis are getting TB drugs, and children who are probably not are having tuberculosis are not getting the drug. So we have to focus a lot on the diagnosis right now, and I think that's where we are upgrading our knowledge on childhood tuberculosis. And once we diagnose that the child has tuberculosis, it is quite easy to treat after that. The treatment might be 6 months long, but it is shown to have good response, and a lot of children do respond to the treatment.
And what if a child comes in contact with somebody with TB? What does one do?
Yeah, so this is a very important situation. Now, if a child comes in contact with any grandparent, most common situation where I see is the grandparents have been diagnosed with tuberculosis, or the mother is diagnosed with tuberculosis, and this child has come in contact with this mother. What do we do then? Most importantly, remember, any child which comes in contact, we have to test. We cannot just presume this child has the bacteria or doesn't have the bacteria. The reason being, if we identify it early and treat it early, we can prevent the complicated forms of tuberculosis. Like I said, the brain fever forms of tuberculosis are abdominal forms which are complicated. So these can definitely be prevented. So what we do in a child who has already been exposed with the contact with tuberculosis, we tend to do this micro test. We see, yes, whether the exposure has happened or not happened. We do a chest X-ray to see whether this tuberculosis is already established in the lung or not. And then we do these gastric lavage. As I said, we put in the tube into the stomach to see whether there is the bacteria present or not by doing a PCR or a staining. If any of these are positive, then we go about treating the child as tuberculosis. Now, what's important is if there is a strong contact, like let's say the grandmother has been taking care of this child for very long and the grandmother has tested positive, it is important that this child gets what we call as prophylaxis. So we are advanced now where we can give one drug which is called INH as prophylaxis. So this child can be prevented from having active tuberculosis. We know the contact is strong, so we can prevent and protect this child from getting the tuberculosis. So we do give INH prophylaxis also in children who have already been exposed to tuberculosis.
Okay. And if a child has already been vaccinated, he still can get TB?
Yeah, definitely. So the vaccine that we give for tuberculosis, as you know, is the BCG. Now BCG is given at birth. Now the efficacy of BCG is shown to be very wide. It can be 0 to 80% and effective usually only up to 5 years of age. Now what does BCG help in is it prevents you from getting severe forms of tuberculosis. It prevents you from getting complicated forms of tuberculosis, but doesn't per se protect you from getting tuberculosis itself. So vaccination is important to prevent the severe forms, but it is not completely foolproof right now.
And Doctor, last but not the least, we would like you to give certain tips to our parents and children on childhood.
So first, most important thing we need to understand is tuberculosis is a treatable condition, right? And I think the message that we need to carry is, yes, TB is treatable. So let us treat it, not get scared or get afraid that a diagnosis of tuberculosis is made. Because if we diagnose it early and we treat it early, the outcome is shown to be relatively good and we prevent a large number of complications. So if you know that a child has been exposed to any adult with tuberculosis, get the child worked up immediately and start off on either prophylaxis to prevent this child from getting the disease or whether we need to treat the child. Don't resist when your doctor says, this could be suspected tuberculosis, we need to work it up. I don't think we should resist it. If there is even a slightest suspicion of tuberculosis and it being a preventable and treatable condition, we should treat it and prevent it. So let us together fight against tuberculosis because we already have the armory to fight it. But I just think we need to all to get together and fight this disease.
We would like to thank Dr. Bharath for the wonderful knowledge that he has shared with us. Thank you.
Thank you.